of right ear discharge since 10 years, left ear discharge since 7 years, and left ear decreased hearing since 5 years. History of present illness. Patient was apparently well 10 years back when she developed right ear discharge, which was insidious in onset, gradually progressive, intermittent, 4 to 5 episodes per year, yellow in color, mucopurulent, profuse in amount, non-foul smelling, not blood stained, aggravated with common cold, and relieved with medication. Since last 3 to 4 years, the discharge was on and off, became scanty in amount, non-foul smelling, and occasionally blood stained.
Okay, Amir Doctor, this was your entire history for the right ear, right?
Yes, sir. Yes, sir.
इसमें what are the chief complaints of ear that you should ask?
Sir, we'll ask for history of discharge, decreased hearing.
Anything else apart from that?
Vertigo, any history of vertigo, tinnitus.
Okay. जो discharge है उसको आप how do you quantify, like what are the 3 characteristics that you will ask for discharge?
Sir, color, consistency, amount.
Okay, amount, color and consistency. ठीक है, that's good. So like supposedly what you are saying is your discharge is profuse in amount, right?
Yes.
You're saying the discharge is profuse, discharge is mucopurulent. तो
Yes.
mucopurulent discharge जनरली किसमें देखा जाता है in this type of disease?
Some mucopurulent when there is secondary infection in squamous in mucosal type of disease, in COM, secondary infection.
So first thing you said is COM with secondary infection.
Yes,
okay.
sir.
Secondary, whether it's mucosal or squamous, or rather I'll put it in the examiner's word, whether it is tubotympanic or eticoenteral.
Yes, sir.
हाँ, किसमें दिखता? Mucopurulent किसमें दिखता discharge?
Mucopurulent in tubotympanic.
Tubotympanic, ठीक है? So one thing is that ये देखा. अच्छा, serous discharge कहाँ पे दिखता है?
Sir, viral laryngitis.
Allergic diseases, okay.
Viral laryngitis and so viral is granular laryngitis.
Okay.
And one more, I'm not able to.
So basically in where the allergic component is involved, where the disease of external canal is involved. Okay. Okay. Now you told about that this is foul smell, non-foul smelling. So when will be the discharge foul smelling?
Foul smelling discharge when there is putrefaction present.
Yeah, great. ठीक है. And same for the second question. When will it be blood stained?
So when there is a presence of granulation tissue.
ठीक है. ठीक. चलिए आगे चलिए please.
It's not moving.
That is Murphy's law.
It's stuck here.
मोबाइल से एक बार ट्राई कर लीजिए. अभी इट वाज गोइंग ना, एक बार या तो लॉग आउट करके दोबारा लॉग इन कर लो. चलो, for the house till that time, the discharge that you will see always like quantify it in 3 types. What is the amount, what is the color and what is the consistency. ठीक है. तो अमाउंट पे अगर बात करते हैं तो अमाउंट में इट इधर कैन बी स्कैंटी और इट कैन बी प्रोफ्यूज. Okay, तो scanty वाला जो है that will be in our disease, that is the eticoenteral disease, because it is due to the osteitis, that is the continuous relentless process which is going on. Whereas in the tubotympanic type, जो mucosal type है, उसमें there is involvement of the middle ear mucosa which consists of the goblet cells. उसकी वजह से there is lots and lots of discharge, and the patient gives the complaint that the discharge comes out of the ear so much that it might stain her clothes, it might stain the pillow cover. Okay.
So can you add? From my phone.
What happened?
So can you add me? I've asked you to join.
एक सेकंड. हाँ जी डॉक्टर साहब, हो रहा है?
Sir, trying to do it. So give me 2
अच्छा,
minutes.
जी जी जी. It's moving. हो रहा है शेयर.
Then left ear discharge since 7 years, which was insidious in onset, gradually progressive, intermittent in nature, 3 to 4 episodes per year, yellow in color, mucopurulent, profuse in amount, non-foul smelling, not blood stained, aggravated with common cold, and relieved with medication in the form of oral antibiotics and topical ear drops.
So basically, in your case, the discharge is present in both the ears.
Yes, sir.
And it is yellow in color both ears, mucopurulent both ears, profuse, non-foul smelling, and not bloodstained in both ears.
Yes, sir. But right here, the discharge changed later on. It became scanty and foul smelling, and it remains the same in the left ear.
Changed later on, matlab?
So earlier, since 10 years, she had this discharge, which was intermittent, foul, yellow in color, mucopurulent, and in the last line I've mentioned, in the last 3 to 4 years, it has now become scanty and foul smelling and occasionally bloodstained.
So, like if you utter this thing in the exam, na, तो वहाँ पे आपका viva will go in this direction. When will squamous changes develop in mucosal thing? ठीक है?
Okay,
तो इसलिए always keep it simple. Whatever the patient utters, that is absolutely a different story. But when you are going to give in the exam, you know the final diagnosis, na? Diagnosis आपको पता है कि this is bilateral cilium with the squamous on the right and mucosal on the left.
Yes, sir.
This is what is happening. Okay. So you should amend the history. This is what I should tell you, because आप यहाँ पे you are starting with all the clinical things, the clinical pearls which are indicative of mucosal disease. अभी this will be my next question कि like अच्छा ठीक है, history के हिसाब से what is your diagnosis till now? So based on history we are going on the mucosal, but after the examination it will change to squamous. So things will not match and viva will not go in the direction that you have thought of. ठीक है?
I'll take care of it, sir.
हाँ, इसको this is for everyone. Okay, don't get waved off. I'll say कि patient ने बिल्कुल ऐसे बोला. You know the answer at the end of the case. What is squamous? What is mucosal? So if it is mucosal, then go ahead. But I say you will not be so lucky कि mucosal आपको मिल जाए. ठीक है, डॉक्टर महेश आर्य, please mute yourself. हाँ जी.
I want to interrupt. I just want maybe she is talking about secondary acquired cholesteatoma. So previously it was mucosal cilium, and then it became squamous because of secondary acquired cholesteatoma.
Absolutely, yes. These things can happen. But the point which I'm like, my thing is कि to make life simple in the exam. ठीक है?
Yes, sir.
The thing is कि you will utter more. Either you should know all the details about it and pray that everything goes as you have planned. But if you have not, this is my suggestion to keep it simple. Simple eticoenteral disease, simple वही clinical vignettes बोलने हैं. That same history collaborating with the same examination. ठीक है? These things are good for the symposium, CMEs, जहाँ पे everybody is throwing his knowledge कि these are the recent advances, blah blah blah, all those things. But for exam, this is my take that please go with the basic findings.
Okay,
ठीक है? बाकी it's up to like everyone is open. सबका अपना exam है ना? ठीक है. चलो आगे चलो.
Then patient complained of left ear decreased hearing since 5 years, which was insidious in onset, gradually progressive. Patient was unable to hear whispers and normal conversation, able to hear telephone and doorbell, and hearing improved during discharge. Patient prefers the right ear for telephonic conversation, and it was non-fluctuant.
Non-fluctuant, okay. So, doctor, what are the causes of fluctuant hearing loss?
So, serous otitis media, Meniere's disease, and perilymphatic fistula.
Okay, and in case of CM with active discharge, ठीक है, mucosal में, it can happen, ठीक है. And you said about the discharge that you were talking about, okay?
Yes.
So there are 3-4 questions that are stat questions about the discharge. The first thing being that why there is the discharge of CM squamous, why it is scanty, okay? So you should be ready with the answer. One. Second is why the discharge in tubotympanic type is profuse. Okay.
Yes, sir, I know that.
हाँ जी, start answer है कि in the tubotympanic type there is involvement of the middle ear mucosa. There contains of lots of goblet cells, so the discharge is profuse. Vis-a-vis, in this squamous type there is relentless osteitis which is going on. Therefore the discharge is scanty, but the discharge is continuous. Okay, because it's a continuous relentless process. तो आपको patient generally gives history कि हमेशा थोड़ा गीला रहता है, but it does not come out of the ear. ठीक है.
Yes, and there is no contact with the middle ear mucosa also, sir.
जी बिल्कुल. And दूसरा question will be same goes for the foul smelling and the blood stain. Okay, why is it foul smelling? Why is it blood stain discharge? Okay, अभी आप पहुंच गए hearing. ठीक है. Proceed. You have told about hearing.
Yes, sir.
So there is no hearing loss in the right ear.
No, sir. Night ear hearing is normal. Yes, sir.
Okay, ठीक है. आगे चले.
Negative history. There is no history of trauma, no history of fever and ear pain, no history of swelling behind the ear, no history of facial asymmetry, drooling of saliva, inability to close the eyes and blow air, no history of ringing sensation in the ear and dizziness, no history of
pain. Doctor, you told about pain. If the patient of COM tells you that he is having pain in the ear, what will come into your mind?
Otitis externa.
Otitis externa. Okay, ठीक है. Otitis externa. What sign is seen in otitis externa?
Sir, tragal tenderness is present.
Tragal tenderness is present. Good. ठीक है. Otitis externa के अलावा anywhere you will see pain, patient will complain of pain.
So master, ASOM.
ASOM ठीक है. चलो, anything else? You started but you changed the topic. ठीक है. All the complications में mastocytitis is one which will present with pain, and for everyone, please, the complications of CM is a must know topic. From where you have read, please update your notes with Shambog. The complications of CM from Shambog, please update it. It will haunt you till you pass your exam. उसके बाद ठीक है, that's pretty okay, but important है. अच्छा, why did you ask for fever? If a person of CM comes to you with fever, what could be the DDs which will come to your mind?
So intracranial complications like meningitis, brain abscess.
Anything else?
Lateral sinus thrombophlebitis.
हाँ जी, lateral sinus thrombophlebitis. ठीक है. Now all three contains two different questions. Like your brain, you said about brain abscess. Note down the question. There are few stages of brain abscess that you are supposed to know, but in today's era, we see the patients of this sort. So it becomes, I'll say, a little bit less relevant for us, but it's a like traditional age-old theory question. One.
So it is a theory question also, brain abscess.
तो ऐसे ही है. तो this is a viva question also. तो आपको all the three stages you have to utter it out. ठीक है. First one, which what did you say before the brain abscess?
Meningitis, sir.
Meningitis. So both these signs, Kernig's and Brudzinski sign, they should be on your tip. You should not jumble it up कि Kernig's में Brudzinski बोल रहे हैं, Brudzinski में Kernig's बोल रहे हैं. It is an important OSCE question also because it is from the complication section. This is important. ठीक है. Then lateral sinus thrombophlebitis, the fever which comes, the name classically how do you describe it?
Get
fever. Good, doctor. Absolutely good. So this is also an OSCE question also, and a very important viva question also. Then fourth question from this place is, what is the sign seen in CT in lateral sinus thrombophlebitis?
So delta sign.
हाँ, empty delta sign. ठीक है, बिल्कुल सही है. ठीक है. So you told about swelling, fever and ear pain. Good. Now why did you ask about swelling behind the ear? I'm sorry, I'll थोड़ा सा ना, we'll extend it all. What yes, questions will come, we'll just keep on putting in between, and so that it becomes a compiled list. ठीक है. What all swelling do you expect behind the ear?
So any abscesses and abscesses, lukes, all the abscesses, and sir mastocytitis swelling present in mastocytitis.
So, in case यहाँ पे ठीक है. This is a question from your examination. We'll discuss it in examination 3.5 and ये examination में discuss करेंगे.
Yes.
ठीक है. Then you told about facial asymmetry. Okay. Here only you have told about facial nerve, drooling of saliva.
Yes.
ठीक है. Okay. What is the reason for double vision?
Sir, involvement of the sixth nerve, ruling out petrous epicitis.
Okay. What is Grady-Negro syndrome?
Sir, it is relentless ear discharge, persistent ear discharge, and sir, diplopia, rectus palsy, and so more. I'm not able to report.
Third is deep-seated retroorbital pain.
Deep-seated retroorbital pain, yes, sir.
आप बाकी लोग भी बीच में यू कैन लाइक अनम्यूट योरसेल्फ एंड आंसर, ठीक है, इट्स जस्ट अ फ्रेंडली डिस्कशन, ठीक है. ठीक है, 3 हो गया. तो these all for ruling out petrositis you asked about this thing. Now उसके ऊपर you have asked about tinnitus. So when does if the patient tells you कि डॉक्टर साहब मेरे को tinnitus हो रहा है, so what will come to your mind कि what is happening with him?
Involvement is happening.
Okay, good. ठीक. And when he tells about vertigo also कि सर मेरे को चक्कर आ रहा है, तो then what will come to him?
Labyrinth involved. Labyrinthitis complications.
ठीक है डॉक्टर साहब, ठीक है. बट माय सजेशन विल बी कीप ऑल दीज थिंग्स इन योर नेगेटिव हिस्ट्री कि ये सब कुछ भी नहीं हो रहा है उसको, ठीक है. बिकॉज लेट इट बी अ सिंपल क्वेश्चन कि हाँ, बिकॉज इफ योर वाइवा गोज फ्रॉम रूटीन ट्रैक टू इनर ईयर एनामलीज, लैब्रिंथाइटिस in this stage only, so थोड़ा सा difficult हो जाएगा. So let it just build it slowly in the initial settings and उसके बाद धीरे धीरे build करेंगे. So my suggestion, negative history, keep everything negative. अरे कहाँ चले गए? हाँ ठीक है, present आगे चलो.
So past history, no history suggestive of hypertension, diabetes mellitus, seizures, any allergic or vasomotor rhinitis, asthma and tuberculosis, and no history of any allergic drug history. And no history of ear surgery and any hospitalization in the past. And coming to the personal history, patient consumes a vegetarian diet. The patient has regular bladder and bowel habits, regular sleep pattern, no history of substance abuse, and family history is not significant, and there is no deafness history in the family.
Okay, ठीक है, चलो आगे.
Socioeconomic history, there are 4 members in the family, and patient belongs to a lower middle class according to modified Kupuswamy scale.
Okay, so this is a very non-specific question. Why is this important? Why this history you have taken? Why is this important? Any point from your side?
So because URTI is more common in lower socioeconomic strata, and it can be the cause of COM.
So you have to mention कि sir there is like less ventilation. Okay.
Yes, and less ventilation.
हाँ, ये वाला point डालना है. Overcrowding है, वो PSM की पहल है, ठीक है, कि there is overcrowding है, more people in one room, so there is like increased risk of these infections, and then URTI, recurrent URTI leading to this infection. ठीक है. आगे चलें.
So general physical.
So till now you have completed your history examination till now. Okay, based on history, what do you think the history which you have given for both the years, that is the discharge and hearing loss? So as per history, what do you think? What is it the case you have got?
So right-sided it is squamosal, and left-sided it is active mucosal disease.
Okay, so you are saying right-sided squamosal and left-sided. ठीक है. Any changes you would like to bring in your history? अगर आप squamosal बोल रहे हैं?
Sir, aticoantral, sir.
Yeah, aticoantral.
Aticoantral and tubotympanic, sir.
Okay, ठीक है. So ठीक, चलिए आगे चलें.
General physical examination. Patient was calm, conscious, cooperative, and well oriented to time, place, and person. General condition of the patient was fair. There was no pallor, icterus, clumping, cyanosis, lymphadenopathy, and pedal edema. Vitals, blood pressure 120/76, done in the right arm, sitting position. Pulse rate was 78 beats per minute, regular, good volume pulse. Respiratory rate was 16 per minute, regular, and cranial nerve examination was normal.
ठीक, यहाँ पे 2 things from my side. 1, please don't use the mnemonic pickle. ठीक है, जैसे you have explained it full, no pallor, icterus, clubbing, cyanosis, पूरा बोलना है, no pickle. ठीक है. 1. Second, we are mentioning BP 120, 70, 80, whatever you are writing. Please एक बार ward में just एक बार नजर घुमा लेना कि is there a BP apparatus kept somewhere. Whether you use it or don't use it, pretty okay. But if the examiner finds you in this situation, अच्छा डॉक्टर साहब 120, 76 लिखा है BP, how did you measure it? ठीक है. So it becomes a little bit awkward situation. ठीक है, तो थोड़ा सा वहाँ पे already there will be SR and JR1, JR2 who will be there to help you out. ठीक है, तो थोड़ा सा पूछ लेना before putting this thing. And if you don't find it, तो mention कि sir I would like to take BP, but the instrument नहीं था, so that's why I couldn't take it. ठीक है. Now there is some importance of this pallor which you have told. Any importance of pallor?
So pallor in cases of lateral sinus thrombophlebitis, general anemia.
एनीमिया पॉइंट भी, हाँ एनीमिया भी बोलना है.
Yes, sir.
ठीक, चलो आगे चलो. Any importance of tachycardia over here? नहीं.
So bradycardia, sir, and brain abscess only.
Bradycardia, good. ठीक, तो all questions from this side covered. ठीक, आगे चले.
So coming to the local examination, I would like to examine the right ear first. was normal in size, shape, and position. There was no scar sign, stag, swelling present. In the post region, there was no scar, sinus, fistula, and swelling. Tragal tenderness was absent, and external auditory canal was normal. And
what is the normal size of pinna? Normal position of pinna?
So position 15 to 22 degree angle with the skull on both the sides, and sir, it extends from the supraorbital ridge to the ala of nose, sir.
So these kind of non-specific question will also be thrown at you. Okay, so be ready for it. What is pseudocyst of ear?
Pseudocyst.
या boxer's ear जिसको बोलते हैं, cauliflower ear, boxer's ear. What is it?
Seroma.
हाँ जी डॉक्टर साहब. So this is collection. हाँ, this is collection of serous fluid between the perichondrium and the cartilage. ठीक है? So that's why you see that swelling in the pinna. So you have told about pinna. Okay.
Yes.
Now in preauricular region, what abnormality, like you say that tags है. मान लीजिए अगर if some tags are present, so
Yes,
what
sir.
is the importance of those tags?
So congenital anomaly like preauricular sinus or fistula.
Good. ठीक है ना? Now come to
Yes.
post auricular region. So what else? You already told कि you can see the abscesses and all.
Surgery,
So
sir, and
हाँ जी. तो remember all the names of named abscesses जितने भी हैं. Please remember ये this is a very potential viva question, oblique OSCE question. दोनों ही. चाहे like ranging from your satellis, zygomatic, all can come from this section. ठीक है? This is important. Now fourth question. There is very important, not important I'll say. Viva के हिसाब से important है. कि what is the difference? Like you see the post auricular groove. We see ना basically.
Yes, sir.
So what is the difference between the changes in this post auricular groove in furunculosis versus mastocytosis?
So it is obliterated in case of furunculosis, but it is not obliterated in case of mastocytosis.
तो ये आपको this will confusion will keep on coming where it is accentuated, whether it is obliterated, outward and lateral pinna किस में आ रहा है, outward and downward किस में आ रहा है. तो this is an important thing. ठीक है. Now for the हाँ जी for the pinna one more question I shared it in the group. वो आपका OSCE भी है. What is frank sign? जिन्होंने बोला हुआ था ऑलरेडी दो लोगों ने ग्रुप पे आंसर डाला था. डॉक्टर ज्योति ने, आप मत बोलना. Let someone else also try.
So I don't know. I haven't
कोई बात नहीं, जिसका एग्जाम होता है उसको नहीं पता होता है. ठीक.
Diagonal crease over ear.
यस डॉक्टर साहब. ठीक है. तो अगर आपका इन दी पिना बेसिकली फ्रॉम दी ट्रेगस टू द ईयर लोब एज, इफ देयर इज अ डायगोनल ईयर लोब क्रीज, DLEC शॉर्ट फॉर्म में लिखा हुआ है, एंड एवरीवेयर यू विल फाइंड इट रिटन एज DLEC. ठीक है. जस्ट सी द इमेज व्हिच आई हैव शेयर्ड ऑन द ग्रुप. ठीक है. सो दिस इज द इंडिकेटर फॉर CAD, पेरिफेरल वैस्कुलर डिसीज एंड स्ट्रोक. ठीक है. जस्ट क्रीज DLEC.
Okay,
ठीक है. डायगोनल ईयर लोब क्रीज इस तरीके से ही दिया है. सो इफ दिस इज सीन इन द पिना, सो इट इज अ इंडिकेटर फॉर CAD, पेरिफेरल वैस्कुलर डिसीज एंड स्ट्रोक. दिस साइन इज कॉल्ड एज फ्रैंक साइन. ठीक है. सो दिस कैन बी अ OSCE क्वेश्चन, पोटेंशियल OSCE क्वेश्चन डाल के पूछ सकते हैं. ठीक है. एंड आपका क्या बोलते हैं, ऑब्वियसली वाइवा में तो इट कैन आल्सो कम. अच्छा. नाउ प्लीज टेल व्हाट इज आयरनिंग आउट ऑफ mastoid region?
So it is seen in mastocytosis.
ओके. क्या होता है उसमें?
So swelling of the periosteum of the mastoid region, sir.
Okay, so what happens after the swelling? अगर आयरनिंग बोल रहे हैं तो कुछ
appearance देता है, sir.
हाँ जी. So because of the periosteoitis, there is thickening of the periosteal area.
Yes,
So
sir.
whatever the bumps which are normally present, normally palpable, those bumps are not palpable, है ना?
They are
So there is
smoothened
smoothened और ironed out feel आ जाता है.
Yes, sir.
इसके लिए ठीक है. Just a minute यार, एक मिनट. हेलो. हाँ हाँ जय हिंद. बताइए. मैं आपको सब 15-20 मिनट से कॉल करूं. एक क्लास के बीच में हूं. मैं आपको 20 मिनट से कॉल करता हूं. ठीक है जी. ओके. आई एम सॉरी फॉर डिस्टर्बेंस. हाँ. तो ये आयरनिंग आउट अपीयरेंस हो गया, डायगोनल ईयर क्रीज हो गया. ओके. ठीक है. चले आगे चलें प्लीज.
Okay, sir. So coming to the otoscopic examination.
एंड सेम 2 more questions from that only. आयरनिंग आउट के बाद व्हाट इज ग्रीजिंगर साइन?
So it is swelling in the post-oral region, swelling and edema.
Pitting edema. Remember the name. ठीक है. Pitting edema of the post auricular region. Why
Because of
does
it,
it happen?
thrombosis of the mastoid emissary veins.
हाँ जी. करेक्ट. Now एक और चीज यहीं पे आती है. What is battle sign?
Seen in middle cranial fossa fracture.
Fracture. Okay. What is seen? होता क्या है इसमें?
Bluish
Which is present in the post-auricular region.
हाँ जी डॉक्टर
Bluish discoloration.
Bluish discoloration seen in the post-auricular region because of trauma basically to skull base middle cranial fossa and there tearing of the emissary veins. ठीक है, अपना ये देख लिया, ट्राइगल टेंडरनेस बता दिया. Then again same question, 3-point tenderness. Where will you put your index finger? Where will be the middle finger? This is important.
Thumb on the mastoid tip and index finger on the scimba concha and middle finger on the
what I have read is my middle finger scimba concha मुझे याद आ रहा है. ठीक है, तो एक बार प्लीज चेक इट वंस. ठीक है, माइट बी मतलब थोड़ी कंफ्यूजन हर बार होता है, तो एक बार देख लेना. आप एग्जाम जा रहे हो तो लाइक इसमें कुछ गलती नहीं होनी चाहिए. दिस इज अ इंपॉर्टेंट क्वेश्चन.
I'll check.
ये हो. Okay, now come to the EAC. What all things can you find in EAC which will be important for you?
So any presence of any discharge, any mass in the EAC, and
Any pustule or follicle.
हाँ जी डॉक्टर साहब.
by any mass and any kind of discharge present in the external aortic canal.
Okay. Anything which will help you in surgical planning?
If it is narrow or wide.
That is also good. As a fresh resident, you will find कि जब हम लोग रेसिडेंसी में थे तो we were told कि कैनाल बड़ा होना चाहिए and perforation छोटा होना चाहिए. That gives you a confidence, है ना? So that is okay. But यहाँ पे you should answer deep canal erosion. ठीक है. So deep canal wall erosion will आपका जब surgical planning करोगे for canal wall down, oblique canal wall up, तो this is an indication for canal wall down. ठीक है. This is important. Then your lux abscess can be seen, sagging of the postomedial wall. ठीक है. चलो आगे चलो.
So coming to the otoscopic examination of the right ear. So I'll start with the.
Hello.
Posterior.
Sir, I had a doubt regarding the discharge. We are often asked about causes of foul smelling discharge and causes of scant discharge in COM.
हाँ.
If you can elicit.
See, in the squamous के लिए basically you have to answer this only कि there is scanty discharge and foul smelling discharge. अब reason क्या है? उसके दो reason है. पहला, for scanty discharge the reason is कि what is happening is there is osteitis of the bones. ठीक है. तो that osteitis of the bones is basically a like small bones है, तो there is small discharge will be coming out. Okay. Vis-a-vis जो आपका the tubotympanic part is there, वहाँ पे the main pathology is lying in the middle ear mucosa where there are goblet cells. So they are secreting that profuse discharge. So that is one difference कि इसमें profuse क्यों हो रहा है and why scanty is there in this side. One. Second thing you talked about foul smelling. So because there is like क्या बोलते हैं because of this infection of the bones which is happening, the osteitis which is happening, there are bacteria which are degrading the bones. There is rotting of the bones which is happening because of which this foul smelling discharge is coming.
So we can say, sir, proteolytic organism.
हाँ जी. This is a very common question also. अभी अपन आगे we are moving ahead. So this will be this have noted it down. Very common viva question. कि why does this what happens in cholesteatoma that the bones start to getting erode? Okay, so वहाँ पे you have to answer this thing only. It's like you have to answer accordingly. कि there is pressure necrosis, there is enzymatic degradation, hyperemic decalcification, and finally the enzymes that you have to answer. Those are your elastase, proteases, and your MMPs. There are multiple MMPs that you are answering in the cholesteatoma. So all these things basically erode the bones.
Yes, sir.
Because of this erosion, आपका जो discharge है, it becomes foul smelling compared to the non-foul smelling discharge of your tubotympanic. हाँ जी.
Thank you, sir.
ठीक है डॉक्टर साहब, आगे चले.
Yes, so otoscopic examination of the right ear first. So the anterior and posterior malleolar folds were prominent, and the lateral parts of malleus was prominent. And coming on to the pars tensa. So pars tensa, so there was a tympanosclerotic patch present in the posterior superior and posterior inferior quadrant, more in the posterior superior quadrant. And there was a tympanic membrane retraction grade 2 in the pars tensa, and coming to the pars flaccida, so there were 2 retraction pockets grade 1 seen in the pars flaccida.
अच्छा डॉक्टर साहब, 2 questions over here. What is the classification name for the retraction of your pars tensa?
So Sarday's classification for pars tensa.
Sade and Burko's classification. ठीक है. Remember its type, है ना? Confuse नहीं होना है. This is, I'll tell you, it's very important and very likely to get confused. Okay. One. Second, then you talked about that there are two retraction pockets present in the pars flaccida. है ना?
Yes.
So what is the name of classification used for retraction over there? TOS classification. Again same thing. You should not jumble it up. जो भी आप बोल रहे हैं, be fixed on that and get like see how I would like to answer this. कि sir there is grade 2 TOS retraction. ठीक है? Like जैसे आपने बोला कि retraction में ऐसा दिख रहा है. Just say TOS grade 2 and just give a pause for 2 seconds and let examiner ask you, अच्छा, what is TOS classification? So then just fire it at him. Sir, this is the retraction classification for pars flaccida. 1, 2, 3, 4. Tak. So it gives you an edge over the routine answering which you have been going. And believe me, इस तरीके से if you lead the examiner in 2-3 questions only, you are ahead of that 50% mark. Then you don't have to think कि मेरे 50% आ जाने चाहिए. You will definitely ahead of it. So try and practice 3-4 things like what I did in my residency. This one, ये TOS grade 2 हमेशा चपका देता था. If you are getting squamous, so either it will be grade 2 or grade 3, grade 4 भी हो सकता है. So this I used to put 1. Second, in between I used to put this Mary's index somewhere in the examination. कि sir Mary's index is so and so, and wait for the examiner. अच्छा पूछेगा वो what is Mary's index, and I'm ready with my answers of Mary's index because we all have prepared long answer on Mary's index. Okay, so these 3-4 things, be ready. It will help you get 60-70% marks in your long case. And these question which you will get, this will help you. जो भी आपका एक आध इधर goof up पड़ेगा कोई टेबल वाइवा में और any ward round, somewhere there will be one goof up. Definitely it is gonna happen. और might be कुछ OSCEs खराब हो जाएंगे. तो ये 20 marks will help you in cushioning over there and smooth sailing 150 plus का marks आएगा. ठीक है. Second point from here only, guys, especially for the boys, कि जो case sheet will be given one case sheet कि हाँ ठीक है do it. So don't draw whatever you want in the tympanic membrane diagram. At least draw something legible, because many a times what happens, कि examiner बोलेगा कि give me your case sheet. ठीक है, what diagram of TM have you drawn? ठीक है, तो अगर आपने वहाँ पे स्माइली बनाया हुआ है तो it will give bad impression. So for the exam purpose, at least basic diagram, if you like, डॉक्टर साहब ने बिल्कुल अच्छा बनाया, like absolutely good. So for the people who have not practiced too much, please practice right कैसे बनाना है, right tympanic membrane, left tympanic membrane, how you will make it. One. Second, normal anatomical landmarks and where you will see retraction pocket, that you have to make. What extra impressions are available, that you have to make. Second point is कि जैसे डॉक्टर साहब started with this describing of this tympanic membrane, as a resident my the main thing is कि sir there is perforation seen over here. No, directly don't jump upon the perforation. First thing is, ideally you should describe whatever you are seeing normally. कि sir there is a dull tympanic membrane which is seen over here. I can see the anterior malleolar fold, oblique posterior malleolar fold, whatever you can see. Sir, I can see the short process of this. Then I can see this long handle of malleus, whether your cone of light is visible or not, that you are mentioning. Then you are seeing the tympanoclerotic patch, usko mention karo. 2. Then you go on the pars tensa, describing the pars tensa, like anything you are finding over there, any retraction. Then the same for pars flaccida, and if any perforation is there, that also you have to mention. So इस तरीके से when you will answer, there will be 4-5 points for you to answer, rather than directly jumping कि sir there is perforation. ऐसा नहीं करने का. ठीक है, अभी आगे चलिए.
So otoscopic examination of the left ear. The anterior and posterior malleolar folds were seen. Angle of Leyes was foreshortened, and coming on to the pars tensa. Pars tensa, there was a large central perforation present involving all the quadrants. Margins of the perforation were smooth, and through the perforation, medullary mucosa was seen, which was red and congested. On the anterior inferior quadrant, eustachian tube opening is visible, and posterior inferiorly, so the round window niche can be seen. And sir, coming on to the pars flaccida, so the attic area appears to be normal.
ठीक है, so this is basically your defining the findings of your tuberotympanic type.
Yes.
In the previous one you told about the retraction. So doctor, where does the retraction commonly start?
It's a Prusak space.
What are the boundaries of Prusak space?
So prusik space superiorly by the lateral malleolar fold, inferiorly by the lateral process of malleus, medially by the neck of malleus, and laterally by the pars flaccida of the shrapnel malleus.
Okay, Doctor, that's good. And here only two questions more. Please read about theories of cholesteatoma. 1. Second, spread of cholesteatoma. 2. And third, a very stupid question, define cholesteatoma. ठीक है, because he might ask you, and अगर हमने we have not ratified it, तो वहाँ पे to frame an answer is थोड़ा difficult हो जाता है. ठीक है, these three questions, theories of cholesteatoma, all like starting से वो traditional theory से लेके और हाँ exactly है ना, traditional theory से लेके जो latest आपकी mucosal traction theory है by Jackler of 2015. ठीक है, still here you should remember. Then you spread, you should remember, and spread as well.
और inside also like what we learn.
At least names तो पता होने चाहिए. ठीक है, at least names तो तुरंत बताना. एक आध कोई पकड़ लो जिसको you should know in detail. ठीक है, मोटा मोटा तो everything is same, only they every time what people have done, they will change the name of something. मोटा 90% will remain same. They will change something and make life of residents hell कि हाँ मैंने extra paper बना दिया. This is what we are doing as of now today also. तो and third thing is spread of cholesteatoma. ठीक है, तो make a flow chart and remember if he asks you कि अच्छा डॉक्टर साहब यहाँ cholesteatoma बन गया, how will it spread? So don't get stuck on that question. These three questions might be there, and if they are there, so it will make your life little bit difficult if you have not practiced it. ठीक है, आगे चलिए please.
So coming on to the clinical test, I performed the folk tests. So on the right side, Renee's was positive with 256, 5 and 12 and 1024 hertz, and sir, on the left ear it was negative with 256 and 5 and 12, but positive with 1024. And sir, Weber's lateralized to the left side.
अच्छा.
So loop bone conduction test was.
So, Doctor Sahab, if you are having only tuning fork test, tuning fork available with you, will you able to tell me like Weber or Renee's which is more sensitive?
So Weber's test is more sensitive.
Why?
So because it can detect a difference of up to 5 to 7 decibel between.
7 decibel. Whereas for Renee's, what is the minimum hearing loss should be there? 15 decibel. Okay. Can you quantify it, the hearing loss based on your tuning fork test? Mild, moderate, severe कैसे होगा?
Yes, sir. So if it is negative with 256 and positive with 5 and 2 and 1024, it is mild conductive hearing loss. It is mild conductive hearing loss. It is if it is negative with both 256 and 5 and 12, it is moderate conductive hearing loss. And if it is negative with all of the three, then it is severe conductive hearing loss.
Acha, based on your tuning fork test and history, there is no hearing loss in the right side.
Yes,
है ना? But there was discharge, there was retraction pocket, there was a thick tympanoclerotic patch, है ना? तो यहाँ पे my suggestion will be always correlate all the three things: history, examination and test. Like अगर मैं इसको present कर रहा होता तो मैं right में at least 256 negative लिख देना था. ठीक है, so that examiner will not put you in this question कि एक तरफ you are saying कि these are the findings, okay, कि there is a thick TS patch, there is retraction pocket, there is erosion and discharge हो रहा है and hearing loss है ही नहीं. ठीक है, so this is how to save yourself from unnecessary questions. Okay, then ये हो गया, ठीक है, वेबर हो गया, TFT हो गया, ठीक है, आगे चलें.
So the facial nerve motor function was intact on both the sides. Nystagmus was absent on both the sides. And the fistula test.
Sorry to interrupt, sir. Regarding tuning fork test, sir, often we are asked a lot of questions regarding that. What are the two types of tuning fork, and who are the scientists who discovered it? And often I am unable to know which book to read for this.
It is given in the which you shared that PDF of that 100.
Exactly, no. Given in that around 5-6 questions are only for the tuning forks.
So name is also given, sir. Hartman and Dingwitz.
हाँ जी, है ना, वो please read that PDF. It's मोटा covered है उसमें. ठीक है, and believe me, जब आप when you will be going for the main practicals ना, वो इतना basics में नहीं जाएंगे. वो आपको first year, second year में for grilling you people, grilling residents, sorry, it is a universal thing. है ना, तो for grilling of resident these things are there कि इसका ये बताओ, उसका वो बताओ. Final year में these are the 3-4 questions कि see मोटा what I'll tell you कि when as an examiner you are there in front to check it, so you are basically seeing the approach of the person. ठीक है, approach of the person कि अगर कल को this person is sitting in OPD, whether his approach is correct or not. Okay, knowledge is secondary, approach should be correct. नॉलेज तो अपने आप आ जाता है, एंड टुडे डेट एवरीवन हैज मोबाइल, सबको पता है थ्योरी क्वेश्चन कुछ नहीं आता, तो इट्स बेसिकली फॉर दैट अप्रोच पीपल चेक वन, एंड सेकंड थोड़ा फिर ग्रिलिंग तो है, अदरवाइज फिर देयर इज नो यूज ऑफ एग्जाम इफ दे डोंट ग्रिल यू, ठीक है, तो डोंट वरी, वो थोड़ा सा पेजेस यू जस्ट एक बार रिवाइज कर रहे हैं, इट शुड बी देयर, ठीक है. स्टिल इफ यू गेट स्टक विद सम क्वेश्चन, आप एक बार ग्रुप पे मैसेज कर देना, देयर आर अराउंड 50 ऑफ अस नाउ, एंड विल जस्ट लाइक कम्युनल डिस्कशन हो जाएगा, इट विल बी देयर, डोंट वरी. ठीक है,
थैंक यू सर.
जी आगे चलें.
So the fistular test is negative on both the sides and the cerebellar signs are absent.
So from here, doctor, two questions. What is the name of facial of palsy? Grading of this.
Some House-Brackman grading.
Any other name do you know about apart from House-Brackman grading?
So Sunderland classification.
Sunny Brookman.
Sunny Brookman, yes.
Sunderland आपका nerve injury का classification होता है.
Sunny Brookman.
Sunny Brookman is also from Scott Brown only. हमने कहीं बाहर सुना है. From Scott. ठीक है. अच्छा, fistula test you told. अच्छा, doctor साहब, how do you do fistula test?
So fistula test, sir, we give alternating pressure on the external auditory canal using either with the Siegel speculum, sir, or by pressing the tragus. We do it to check if there's a.
नहीं, अभी आगे बताओ. आपने बताया कि you can use Siegel's pneumatic speculum, one. Second, you can by alternatively you can press. Anything else apart from that you can use?
So I don't know.
You can use otoscope, pneumatic otoscope. You can use the हाँ जी, you can use the impedance audiometry. ठीक है, चारों चीज यूज कर सकते हैं. Now coming to the Siegel pneumatic speculum, what does it contain?
Some a bulb.
Okay. और कुछ?
I don't know the.
There is a oral speculum. ठीक. There is a lens. ठीक.
Magnifying lens.
Yes. Now comes the second question. What kind of lens it is? What magnification does it give? Yeah. What is its power? So it's a biconvex lens which has a power of about 10 diopters, and it gives you roughly a magnification of twice of it. Exact अगर कुछ और है तो please let me know. This is what I remember. 10 diopter and twice of the magnification. Then they will ask you what is the advantages of using this Siegel pneumatic speculum. Would you like to answer?
So I don't know about the Siegel.
Okay, I'll tell you. Anyone else? कोई बोलेगा? So you can check about the mobility of tympanic membrane. You can see the magnification, magnifying glass है, तो you can like have a magnified view. Then you can do the fistula test. You can remove the secretions. You can do the powder insufflation test. ठीक है? Now, fourth question from this section. What is the use of this powder insufflation test? Again, I'll answer. It is for you seeing the difference between. एक तो हो गया drug delivery के लिए, है ना? Like if you want to put boric acid inside the.
So why do we use boric acid?
See, it is for those cases which do not dry for whatever reasons can be there. Like this is my personal experience. I'll not like to quote anything. Like people who are COM operated, still somehow their ear is not getting dry. You have given all antibiotics and called them for daily oral toileting with betadine, but it's not cleaning. So this is what I have seen during the residency and post 5-6 years now. You call them around. हाँ जी.
pH change in pH.
Exactly, डॉक्टर साहब, है ना? तो चाहे बोरिक एसिड हो गया आपका या आपका एसिटिक एसिड आप वॉश देते हैं, so it changes the pH and removes those bacteria. So you call them twice a week and give them either wash with acetic acid or जैसे I prefer using this boric acid. That's the same acid which you use in the carom board. Okay, tell the patient get it from outside and insufflate it. Mota in 10 days, 15 days, the ear becomes absolutely dry and patient is happy. He has only
boric acid. How to insufflate boric acid, sir?
See, like personally, what I do is I know it's a wrong method. People, ideally, should be done by this Siegel speculum only. I do it only with this 5 ml syringe, 5 ml or 2 ml syringe. Remove the needle, push it, and make a funnel side sort of thing with a paper or something, and put it inside the ये क्या बोलते हैं आपका पूरा tympanic membrane पैक कर दो उससे, ठीक है? And use it twice a week for I'll say 2 weeks only, and you will see the difference of this relentless otorrhea which is happening. It will become dry.
Okay, sir.
ठीक है? So ये तो हाँ, this is not to be quoted. This is what I told. This is my personal which I like कि जो सूख नहीं रहा है कान उसके लिए you can use it. Sorry, Dr. Sahab, I couldn't get you. What are you saying?
Sir, you will be putting in powdered form.
हाँ, boric acid is in powder form only. Carrom board, you will play carrom board ना? Carrom board में जो powder डालते हैं ना, the same
red colored powder.
हाँ, it's the same powder. ठीक है. अच्छा, so एग्जाम में क्या बोलना है? एग्जाम के लिए एग्जाम के लिए this powder insufflation test is used to see the difference between a large central perforation and a grossly retracted tympanic membrane. Sometimes there is a confusion ki whether it's a grossly retracted TM oblique whether it's a large central perforation. So yes. One way of checking is either you can do a automicroscopy oblique you can put a autoendoscope. Okay, so that's why ये autoendoscope वगैरह तो अभी पिछले कुछ सालों का advent है. Previously that's why I say the examiner who is of old timer he will ask these type of questions है ना, जो आजकल कोई use नहीं करता. ठीक है. So people used to put this boric acid inside the ear. So in case it's a large central perforation, so that powder will become wet. But if it's a grossly retracted TM, so it will not become wet. So it's indirectly a differentiating factors between both of them. Okay. So you did fistula test, and so here are the general questions that you should remember about it. What is the aim of fistula test? Okay. What is how do you do it? We already discussed about it. What are your findings? False negative, false positive आपको पता होना चाहिए. Grades of nystagmus पता होना चाहिए. Alexander's law and Evolt's law पता होना चाहिए. This will contain complete the entire section. हाँ, last question. What is Henneberg's sign?
It's a false positive fistula test.
हाँ जी. C
syphilis and Meniere's disease.
हाँ जी डॉक्टर साहब. ठीक है. So this completes the questions till now. अब आगे चलिए.
So other ENT examination, so there was a septal deviation with the left present in the nose, and paranasal sinuses were normal, posterior rhinoscopy was normal, oral cavity and neck were normal.
ठीक है. As far as your exam case is concerned, are you expecting any kind of problem in the nose oblique ये?
So yes, it was not, patient did not have any nasal obstruction, but it was my finding that he had left-sided DNS. So.
Anything else that you could expect? Bilateral CM?
So, eustachian dysfunction.
Exactly, doctor. All these your nasopharyngeal things, any eustachian tube dysfunction, yes. Adenoids hypertrophy, allergic findings of allergic rhinitis, all these things. हाँ जी. So these three things, whenever there is bilateral disease, so this you should be careful कि अगर you are having bilateral, so definitely you have to tell about the importance of your rhinoscopy oblique nasopharynx examination. So no, it's good. आगे चलिए please.
So my provisional diagnosis, it is bilateral chronic otitis media with right-sided inactive squamosal, with right-sided normal hearing, and left-sided active mucosal disease with left moderate conductive hearing loss with no intracranial and extracranial complications.
Okay, mota you have covered everything in the diagnosis. Why do you say inactive over here? The first line, right? Inactive. What is the difference between active and inactive?
Squamosal or generally
squamosal.
The presence of choleosteatoma or flakes or any debris, we say it is active squamosal.
Okay.
And in case of inactive, presence of retraction.
Okay. ठीक है. In mucosal disease, what is the difference? Active and inactive?
Perforation of the pars tensa with inflammation of the middle ear mucosa is active mucosal.
Active का मतलब है पस आ रहा है. Discharge is there. ठीक है. Inactive dry ear.
Dry, yes.
Okay, doctor. So you have completed. जी बताइए.
Squamosal is called as active, no, because discharge is there.
No, sir, it
became for squamosal. No. For squamosal, it doesn't depend upon discharge. For squamosal, it depends upon whether the cholecytoma is present or not. ठीक है. तो अगर cholecytoma present है, it is active. If it is not present, it is inactive. ठीक है. Mucosal के लिए अलग है. अच्छा, तो you have completed your diagnosis till now. हाँ बताओ.
Normal hearing की जगह से minimal hearing बोल सकते हैं.
See, she has not given any hearing loss in the tuning fork test, even in the history. So it can go. Like what I will prefer is if there is disease, there will be otorrhea also, there will be hearing loss also. This is what I have like.
So then I should have done mild conductive.
Sir, minimal word use कर सकते हैं.
Mild moderate severe. Minimal कुछ नहीं है.
Minimal.
Minimal. No minimal. Okay. You have to quantify it. Either it is mild, moderate, or severe. Like second line, she has written it correct. कि left active mucosal with left moderate conductive hearing loss without any complication. That's correct.
So I should have written right-sided conductive hearing loss according to you, sir.
Like see, if I would have been given this question, so in the history also, I would have changed it as per as Squamous, like I told you. One, given some hearing loss in right ear also, whether left more than right, that's pretty okay. Then in the examination finding में भी Rennie's negative right side में करता, because conductive hearing loss दिखाना है थोड़ा सा, ठीक है? And in the हाँ जी, and in the diagnosis I would have told like this कि sir this is chronic otitis media. और आपने लिखा ना हाँ chronic otitis media squamous right side with mild hearing loss oblique moderate hearing loss whatever it's again without any complication. And same for the left कि squamous chronic otitis media squamous type left तो आपका mucosal हो गया mucosal type with moderate conductive hearing loss without any complication. ठीक है बाकी it's correct. So it's up to you if you want to change it or not. This is what my observation is. It becomes much more smoother if you answer in this way and avoid unnecessary questions. एक दूसरा चीज which I have seen one problem in the viva. I'll take 5 to 10 minutes more. Just bear up with me. ठीक है I have seen people struggling because जब तक आप ये this generally is the last thing which you do in your viva. Last long case generally last में लोग रखते हैं. You are fatigued, you are tensed, you are just मतलब tired out. ठीक है what I saw when I was in first year, I saw this viva of DND going on, and the candidate was telling कि diagnosis में कि sir the diagnosis is COM right squamous. ठीक है examiner was again and again hinting doctor what is COM, give full form, and mine was so much blocked कि भाई COM का full form नहीं निकल रहा मुझ से. ये like this is what I have seen in front of my own eyes. ठीक है so it's not that he doesn't know it, obviously he knows it, but this is how your mind plays games with you. Okay, so these are the common mistakes which people make. Don't make these mistakes. This is my help which I can like help you out. यार ये गलती होती है, ये गड्ढा है, इधर से मत जाओ, ठीक है बस ये पकड़ना है.
Sir,
this is absolutely
excuse me, sir.
जी बताइए.
Sir, I have one more doubt, sir. While giving the proper diagnosis, should we also mention that there is no intracranial complications or intratemporal complications? Should we have to mention it, sir?
No, it's already she said na, without any complication. Yeah.
Like
if you want to add, it's not necessary. No, it's not necessary.
Okay,
अगर कुछ है, like if you are seeing something कि हाँ complication है, तो then you have to put it in. Otherwise, if you have told कि sir there are without any impending complications, तो it serves the purpose. है ना? So that purpose should be served. अब ultimately if the examiner have decided कि वो will have your happiness, तो he will find out something. ठीक है? Because he has been master in that subject before we were born also. So he will have our happiness if he wants it. तो जनरली ऐसा होता नहीं है. We hope for the best. ठीक है? It's till now it's okay. Now, doctor, one of the most dreaded question. Define COM.
So it is in chronic otitis media is an inflammation of the middle ear cleft.
सही है. ठीक है. इसमें my suggestion is quote Scott Brown. ठीक है. Scott Brown में there is a table where they have mentioned this definition of all the 5 sections. That is COM active, inactive, COM healed. ठीक है. एक टेबल में इन्होंने बना कर रखा हुआ है. तो I'll share the screenshot with you. Rectify it. Otherwise, normally in general senses, it is chronic suppurative inflammation of mucoperiostral lining of the middle ear cleft. You said it right. One. Second, you can
for more than 3 months period करके.
ये जो है 3 months duration ये WHO बोलता है कि it is intermittent or continuous otorrhea through a permanent non-intact tympanic membrane more than 3 month duration. I know.
Okay, sir.
This is the WHO classification. WHO, how does it define it? This is 3 months duration उसमें आता है.
So share the definition for cholesteatoma also. Sir, it is different and different.
मैं आपको सुबह तक I'll share it on the group. 2-3 definitions are there. एक it's very pathetic to learn definitions. I'll tell you once you come on this side. It's so easy. You see the patient. हाँ ठीक है तेरे को ये surgery लगना है. You just go with that. ठीक है. All these things are till you pass your exam. ठीक है. But till that time you have to pass. Bear it up. अच्छा. Now if you have come till this point ना, you have passed your exam. अगर आप diagnosis तक आराम से पहुंच गए ना, you have passed your exam. Now comes the favorite question. Doctor, how will you manage the case? Let's have 5 more minutes of discussion. How do you manage the case?
To investigate my patient first and then counsel surgery.
ठीक है. How will you investigate? क्या करेंगे?
Sir, I will go for the examination under microscopy, sir.
Okay.
And then, sir, X-ray mastoid, followed by HRCT temporal bone.
Examination under microscopy. Okay. Why will you want to examine under microscopy? What will you get extra?
Sir, to look for the extent of cholesteatoma, sir, and the retraction pockets if they are having any granulations or debris, sir, in my case.
Okay. Anything else? इसके अलावा? I would like to confirm my findings. 1. I would like to take first swab culture of it. 2. I would like to secrete out the disease. 3. ठीक है. And 4th जो आपने बोला वो बिल्कुल सही है. ठीक है. आपने you have done automicroscopy. उसके बाद आपने क्या बोला? You will do a PTA, audiometry करेंगे.
Yes, sir.
Why would you like to do a audiometry?
Sir, to see the pre-op hearing loss, to quantify the hearing loss, sir, and then for medical legal purpose, sir, and then pre-operative and post-operative to see.
Now comes the deceptive question of all times. After this, what we would like to do?
Sir, should I say X-ray mastered or HRC?
ठीक है. The thing is कि जो भी कुछ बोलोगे वो आपको फंसा सकता है. This happened with myself. I initially said कि सर X-ray mastoid करेंगे, तो he datofied me किया. Today in today's era of 2000 and people are doing HRCT और तुम X-ray कराएगा, ठीक है? तो डांट पड़ी. Or but if you say HRCT also, then also you are likely to be scolded. We come from a country where CT is not available, patients are poor and all those things. But it's always better to go in the sequential manner. ठीक है कि sir I would like to do X-ray mastoid. This is our institutional protocol. जहाँ भी कभी फंस जाओ, ठीक है? जहाँ पे भी कभी you get stuck where you don't know what to answer, sir, this is our institutional protocol. ठीक है कि sir I like to do X-ray mastoid first. I would like to see this dural angle and आपका mastoid ASF जो routine questions है it will ask, and then sir I would like to confirm it oblique HRCT के लिए बोल दो कि हाँ sir before surgery I am a new surgeon, I would like to do HRCT. ठीक है. There is no shame in saying this thing. Sir, with my experience, I would like to do HRCT temporal bone, because see what happens in otology. There are so like older big daddies of ear, जिनको बोलते हैं wizards of otology. People are like they don't do HRCT. कि जो table पे होगा I'll see and my microscopes and manage it. I don't do it. There are few people of this thinking also, but in the recent times people are like कि नहीं HRCT करना चाहिए. So it is a big dilemma, big dichotomy which happens between people, and ultimately पिसता कौन है? Resident. He is the one who receives गाली at every time. ठीक है. So गाली तो पढ़नी है, but you have to see कि minimal कहाँ से पड़ेगी. So step wise चलना है. X-ray mastoid Schuller's view, all the 3 points, then for your HRCT temporal bone. अच्छा, HRCT temporal bone से ही याद आया. Please सतीश सर का जो वीडियो शेयर किया था, उसको see it 2 times, 3 times before your exam. Likely to you will get one question either in your डायरेक्ट ऑस्की में पूछेंगे, या फिर आपको जो रेडियोलॉजी सेक्शन रहता है, रेडियोलॉजी सेक्शन में दे विल ईदर पुट HRCT टेम्पोरल बोन और NCCT PNS. 99% यही आता है. ठीक है. तो इट इज अ इजी टेबल इफ यू नो हाउ टू आंसर योर CT स्कैन. ठीक है, वो देख लेना. अच्छा, उसके बाद यू विल प्लान फॉर सर्जरी. सो व्हाट काइंड ऑफ सर्जरी विल यू प्लान फॉर दिस पेशेंट?
Sir, in my case, it is a self-cleansing retraction pocket, sir. I will not plan a surgery because hearing is normal in the right ear. So I would not like to do surgery. I will like to do regular suction cleaning and call the patient for follow-up. And if it's still patient is not compliant and if it doesn't heal, then I'll go for surgery, sir.
तो अभी as of now, like the diagnosis which you have painted in this case, ठीक है, you are saying कि it is inactive in the right side without any hearing loss. So right side does not require any surgery per se as of now.
So left side I would like to do
left के लिए you exactly, तो left के लिए you have to answer for what surgical approach you have to take. तो यहाँ पे फंस जाओगे. फंस क्या जाओगे? नहीं फंसोगे नहीं. It's like you would have prepared कि I will answer about canal wall up, canal wall down, but यहाँ पे your question will go into cortical mastectomy. When will you do cortical? When will you not do cortical? You getting my point?
Yes.
If you get this type of questions, so be ready कि viva का pattern will change a little bit. Normally, as a ENT resident, we are habitual of answering these questions only. कि what are the indications of canal wall down? ठीक है, तो जो उसके साथ के associated questions हैं. अच्छा, I'll just change the deviate from the topic. कि these are the start questions which will come. Like normally अगर आप जो routine diagnosis आप बनाते हैं, ठीक है, तो canal wall up, oblique, canal wall down, both the indications, advantage as well as disadvantage, all 3 are important questions. Then comes your what is the ideal cavity? It's a very common question. Then these anatomical landmarks, anterior buttress, posterior buttress, facial ridge, facial bridge, they will ask you, they will keep on grilling you. If you have any confusion, write it down and learn it. Okay? Believe me, 1 month is there, write it down and learn it. Pass your exam and then if you want, you can forget it. Okay? But till exam, you have to remember. हाँ जी बताइए.
सर ये जैसे इसमें ईयर का एग्जामिनेशन पूरा लिखने के बाद इन्होंने लिखा था कि अदर ईएनटी एग्जामिनेशन, तो सर इसमें नोज और थ्रोट पूरा डिटेल में अब लिखना जरूरी नहीं है कि जैसे पहले लिखते नोज
normally in the ear case generally we are expected कि ear you should write in detail, and nose में like only 4 lines that we have to answer. There is no external deformity, bilateral nasal patency adequate, and whether you see any change in the septum, DNS है कि नहीं है, and nasopharynx normal है कि नहीं normal है. These 4 things only you have to write. ठीक है. And going for
डिटेल में थोड़ा उसे लिखना पड़ेगा कि जस्ट 1 लाइन की.
my suggestion don't go for 1 line in long case. ठीक है, anywhere. ठीक है, even if you have to say about oral cavity also, 2-3 लाइन उसमें भी लिख करके रखो. ठीक है, because you don't know what mindset the examiner is sitting over there. Normally the local examination is the thing which is being looked at in detail, but इसके अलावा नीचे भी आपको CVS S1 S2 नॉर्मल करके डालना है, CNS HMF नॉर्मल, नो न्यूरल डेफिसिट, ये करके लिख के छोड़ दो. लॉन्ग केस, दिस इज व्हाट वाज टोल्ड टू अस, like everyone is being trained कि for long case it is entirely full history, full examination, everything in detail. But depends upon the time. अगर टाइम नहीं है तो फिर 2 लाइन लिख करके छोड़ देना. ठीक है, but you should know the importance. Like in the bilateral cases, nose is important. So then तो you have, जैसे इस केस में तो you don't have an option. You have to write it.
Okay sir.
ठीक है डॉक्टर साहब. चलो, anything else from anyone's side? कुछ और पॉइंट किसी का?
Sir, in the exam, if such a case comes, will we be given the HRCT temporal bone also?
No.
And yes, sir.
No.
So the Viva will go on the management only, but will not.
Exactly. It will go upon how would you like to manage. It will not depend upon HRCT में क्या पता चलेगा, है ना, कि कोलेस्टिटोमा कहाँ पे है,